it's a little bit related to your prior question, who are the candidates for SBRT? I said our off protocol is up to 5 lesions. However, there are randomized studies that are looking at up to 10 metastases. That's a Canadian randomized study that is almost completed accrual. It's not just for colorectal cancer patients, but it's a phase 3 study. So I expect there would be a cohort of patients with colorectal carcinoma in that study. So that will be very important to tell us if there is advantages, as we hypothesize there will be. And then in terms of how we deliver radiotherapy, I mentioned already using appropriate staging from a VIST MR, make sure we're treating everything we can see. But in terms of how we give radiation, what we do now is totally different than 10 years ago. It's very focused. We can give quite high doses to the tumor itself with rapid fall off. And some of the tools available to us help us do that. So that's with better imaging at the treatment unit. There's MR integrated with linear accelerator where we can vary and adjust for millimeter changes during treatment. Even if the tumor swells or shrinks a bit, we can adjust day to day. I think that's one aspect of how our therapies are a little better. And similarly with cone beam CT based image guidance, it's improving quite a bit with quicker treatments and again, ability to adjust depending on what we see day to day. So I think both of those treatments will allow potentially a little bit improved therapeutic ratio, more dose safely for patients from a radiation side. The other exciting space is sensitizers. So, studying radiotherapy with sensitizers, but in colorectal cancer, there's so many lines of therapy already that we would usually work with what the standard of care systemic therapy is, and then again, figure out when to use radiotherapy depending on the patient's status.